Welcome, and thank you for attending our webinar. I have some housekeeping notes before we begin. As a provider of continuing education, ICS has specific guidelines and regulations to follow when presenting continuing education events. We appreciate your professionalism and honesty in accurately recording the number of CE hours you attend during any given program. We recommend you be on the webinar screen for the full webinar. The system can tell if you pull up another screen during the webinar, such as your email, and will show you as inattentive during that time. ICS bases the amount of time you are attentive when considering your CE hours. The polling questions will be asked during the webinar. They are also used to gauge your attendance and CE credit hours. You must have your pop-up blockers turned off or hold down your CTRL key in order for the polling questions to work properly. If the polling questions do not function for you, simply write down the question and your answer and fax or email it to me, and you can type it into the question box as well. And the polling questions only work for the live webinar. So if you're watching this as a recording, it doesn't work, and you'll use the paper quiz provided in the email with the webinar recording link for your CE credit. Because of sound quality, it's necessary to keep you muted throughout the program. You have the ability to ask questions using the questions box on your control panel. An online survey will display on your screen when you leave the webinar. Please take 30 seconds to provide us with valuable feedback. Our speaker today is Dr. Mike Powell. Dr. Powell grew up around his father's practice in Guttenberg, Iowa. In 1989, his father, Dr. Kent Powell, suffered a stroke, and in the process of assisting with recovery, Dr. Powell became focused on learning how chiropractic could affect the central nervous system. Since then, he has been in private practice with his wife, Courtney, in Cedar Rapids, Iowa, where the majority of his patients present with complex neurological conditions. Dr. Powell is a diplomate in chiropractic neurology and is an associate professor of neurology with the Carrick Institute for Graduate Studies. He has been teaching courses on how to help those with difficult neurological conditions for the past 14 years. Welcome, Dr. Powell.
Great. Thank you, Denise. That's very, very nice. Good, I guess it's afternoon now. Good afternoon to everybody on a chilly Veterans Day. And we're together today to discuss and have me share any insights that I hopefully can provide on working with folks that have complex issues. And, you know, we all have patients that have complex issues. And some of them are, you know, their diagnosis is complex. You know, they've got some disorder that's just a difficult one. There's just, you know, there is, quote unquote, no treatment for. Or ones that are, you know, very difficult to treat. There's a lot of other complexities as well that people bring with them, as you folks in practice well know. And we're going to try to flesh some of that out. In my practice, those are the majority of people that I see. And so I am certainly no high-level practice management expert, but I've had lots of years of trial and error in working with people with both complex conditions and complex situations. And I think there's some things that that we can look at together that'll help us, you know, get a higher batting average with those folks and increase their success rates and decrease our stress rates when working with them. So let's get rolling. First of all, you know, who is a complex patient? Well, let me just give you a few examples of some folks from my clinic. And I just put this together, a little summary on a couple people that I've just been working with over the course of the last couple weeks as I was putting some things together for our sharing today. So we'll talk about Tracy. I just did Tracy's report of findings with her and her parents yesterday. She's a 15-year-old girl that was playing soccer 14 months ago, and she took an elbow to the right temple and suffered a concussion. And she's been through quite a bit in that time. She's had a couple of rounds of physical therapy. She was seen at the ER right away afterwards, family medical doc within the next couple days. University of Iowa Sports Medicine had her for about 4 or 5 months, most of last winter and early spring. The issue is she's still pretty much the same as she was about 12 months ago. She has headaches every day some dizziness, mental fog, and it's occasionally severe, and she has some level of disability from this multiple days per week. She's utilized a couple different medications. There's one that helped. I listed on there for you, amitriptyline. Didn't help a lot, but a little bit, which is encouraging, but the anxiety and nightmares makes it not such a great trade for her. So basically, she's been stuck at level 1 on the return to play guidelines. So as you know, there's a graduated return to play, and basically being relatively symptom-free is level 1. Level 2 is light aerobic exercise, like a 15 to 20-minute walk on a treadmill. She can't tolerate that. And so she's been at that level where she can't move on to level 2 this whole time. So she's got some things obviously stacked up against her, or she'd gotten better by now. I mean, the majority of people with a concussion are symptom-free in about 10 days. So, you know, something's perpetuating this. And that's one of the key things that we're going to be looking at over this next, 45 minutes or an hour here is when you see people with complex conditions, especially people like Tracy, where most folks that have a similar story, it resolves on them. What's perpetuating this? What is, what's going on? There must be something. Somebody's missing. She's had a good bit of chiropractic care along the way, very, very good chiropractic care, but still, she has not progressed. Ron, about 8 years ago, started to have some trouble walking and was tripping, and his legs weren't doing what he wanted them to do. It was very interesting. With it, after this started, after 2 or 3 years, he really couldn't walk without assistance, but he could run. So a very unique type of deal. Basically, he has a progressive neurological disorder that's damaging the sensory feedback from his legs initially, and it's spreading to other parts of his body, causing him an ataxia. He's had a lot of workups. He's been at the University of Iowa. He's been at Mayo. At one point, he had a Parkinson's diagnosis. That didn't look right. ALS, MS, none of those really look right, and honestly, they don't fit for him. And so this is a 56-year-old, really vibrant, sharp guy that that really can't walk very well at all, and his hands are starting to get involved. And obviously, he's in a complex situation. Jen, I just saw this morning. We've been working with her. We're about a third of the, probably halfway through her initial treatment plan. She was in an auto accident a little over 2 years ago and has basically had a lot of problems ever since. She's probably maybe 20, 30% better than she was, a couple months after the auto accident. But she has daily headache and some issues that are really interfering with her life. She's got 4 young kids, and she is just not able to fully participate in either the care that she needs, because she's got a lot of commitments at home, or being as attentive a mom as she wants to be, because her condition's interfering. She's had really good chiropractic care, a couple different chiropractors, PT, MD, a bunch of different stuff. And so what I wanted to do was just kind of show you some examples of some of the folks, at least that we see on a daily basis here. And I'm sure that you see people with similar stories occasionally at least. How are we going to navigate that? Because the big thing is all 3 of these people have conditions that have been going on for, more than a year, 2 years, 8 years. And so, at that point, usually the prognosis is what you got is what you're going to have. And it's probably going to progress. And so we need to somehow break the cycle on these people. And so let's talk about the things that get in the way of success, and then let's talk about how to deal with those so we can stack things up in our favor, okay, and in favor of these patients so that we make it a good situation for them. Because if they're set up for failure, really, what's the point in coming and seeing us or coming and seeing anybody if they're set up for failure, okay? We want to stack things up the right way. So let's look at some of the things that work against us. The way I think of this is that, you know, for any of those people we just talked about, and lots of other folks, they're in an unreasonable situation. It's just the way it is. We need to recognize that. You know, and they don't have to be neurological conditions like those folks. I see a lot of those people, but it could be things, obviously, that involve the nervous system to some extent, but, you know, it could be a sciatica that's been going on for 9-10 months, is somewhat disabling. They've got some bad discs in their low back, but they're not a surgical case. They've seen 2 different surgeons. Nobody thinks that surgery is really going to resolve their issue, so they're not proceeding with that. So, you know, what do? I mean, they're in daily pain with it. They're in an unreasonable situation. They've been to a couple of different DCs, PTs. They've had injections, same sort of thing. So before we look at any of this, one of the key concepts that I want to share with you is that when you're in an unreasonable situation, you're going to have to do unreasonable things to dig yourself out of that. And what I mean by that is there's a bunch of hurdles that are between you and getting better. And we need to get those out in front of us right away and deal with them from the get-go, or we're really not going to, you know, we're really not going to be able to make much progress. So, treatment plans. The length of your treatment plans need to be unreasonable, maybe. I mean, I know it's taken me quite a few years in practice to want to tell folks, hey, you know what, our treatment plan for you is 6 months or a year or whatever it's going to be. You know, years ago, I really wanted to tell people that, you know, let's get you through 3 weeks. I think we should be able to make a significant difference. Well, the guy that hasn't been able, that's walking's been deteriorating for 8 years, I don't think a 3-week treatment plan does him justice. And if we set up our goals at a 3-week time frame, like we might with a lot of other more typical patients, I don't think that really sets him up for success. I think that sets us up for some disappointment 3 weeks down the road. Although I do think that we can make our treatment plans in smaller bites and do some good things that way. It's going to take a lot of effort on the patient's part, and it's going to be some work. And we're going to talk about the commitment that it's going to take on the part of a patient who has a complex situation to be successful. In terms of money, this is always a big roadblock for patients. The vast majority of them either have diagnoses that chiropractic coverage may not be available for. So just for example, I do not believe that many insurance companies will cover chiropractic care if the treatment is specifically for Parkinson's. Okay? Now, I know that the patients that we see have other issues, including subluxations, that insurance does cover, but the reality of it is a review of your records, at least of my records, is probably going to show in a Parkinsonian patient that I'm doing things that look like they are directly trying to affect the Parkinson's. And in reality, I am. So we need to make sure that we get whatever money issues there are on the table and out in front of them right away. And we're going to talk about how we do that. They're going to have folks at home that have other ideas about how things should be going. They'll have other influences, whether it's family members, other physicians. You know, hey, there's really no treatment for this. I don't know why you're continuing to treat for it, or whatever. You know, I'm a physician. You're a physician. If I assess somebody and I feel there's some things that we can do, then I need to let them know that, and we need to be upfront about that. I have a hard time with the idea that there is no treatment for this. Okay? There is always a treatment for things. You can always be healthier, and healthier people do better with whatever the issue is. Just fill in the blank. As we progress through care, there's guaranteed to be some trial and error. If there wasn't, it wouldn't be complicated. People with simple stuff, a lot of times we come up with a plan that's worked well for pretty much everybody that's had similar issues. And so, there's not a lot of trial and error with them. With these folks, there is, and they need to be aware of that. They also need to be forthcoming with all the issues that are out there on the table. The patient has to come clean. They may have prior issues. They may have, they may be alcoholic. They may have emotional things going on in their families. When we have pretty simple, straightforward things, a lot of times, as clinicians, we can help people with those things and get them a lot better in spite of all that other junk in their lives. But, those people that I just put up there on the list and other folks like them, not so much. We've got to look underneath all the rocks, and they got to come clean to it, or it's going to be a waste of their time and money and a waste of our effort as well. So another hurdle that gets in the way of success is that many times the patient really doesn't want to burden other people in their family with, being away from their kids, with their spouse having to drive them, to appointments, with the financial aspect, and so they hedge on care, or they don't want to fulfill care that takes a long period of time because of that. So we need to get that out in front of us as well. And then finally, just the baggage that's associated with some of the conditions that people have. Let's look at a few of these things in a little bit more detail here. So there's a certain level of commitment that your patients need to have to be successful. And for those of you guys that have been in practice for quite a while, I'm sure that you've come to terms with this, that you need to, as a clinician, put hurdles up in front of your patients before they actually get to see you. I strongly believe that. If your practice model is one of, providing the majority of your patients, you're trying to provide kind of, quick relief for pain, then maybe that's not quite so much the model that you want to have in terms of what I'm recommending here. But what we're talking about is people that quick relief isn't happening, and quick relief isn't what they're after anyway. They've got a long ways to go, and they've had a difficult journey already. It's not going to be easy. So I highly recommend to you, and I think this is one of the more important things I can share with you today, is that you need to put some stuff in between them wanting to see you and them actually getting in to see you, okay? So let's talk about what we do anyway, okay? So I'm going to share one of our models. So complex patient calls in, and our staff identifies them. Now, we have a high percentage of these folks, but, we live in Iowa. If they're from a different area code, I'm in Cedar Rapids. I'm right, in the middle of 319 Iowa area code. If they're from a different area code, they're probably traveling a little ways to get here. If they've been referred by other docs, if, the front desk asks them, what do you want to be seen for, that usually sort of uncovers whether this is going to be a complex patient or not. So complex patient, which are mostly what I see, they will not be scheduled for an appointment. What happens is they will receive our intake information, so they get information from us via email, and it has all the stuff that we need to get from them. Okay, and we'll talk about that in a minute. At any rate, when they complete that information and send it back in, I'm going to sit down and review that. I'm going to spend an hour or so, give or take a little bit, sometimes it's more, sometimes it's less, going over all their stuff. And since it's all got to wind up in their documentation anyway, I don't have somebody else put it in their documentation. I just do it myself. I'm going to have to review the stuff that came from their visit to Mayo Clinic, and the U, and the chiropractic notes, and their all different kinds, in their labs, all different kinds of stuff. So I do that. I personally put that in. So I sit down with it and I try to get that figured out. So the reason I'm kind of sharing that at this point is that since upon receipt of that, I'm going to put some time into it, they send us a fee for me reviewing all their records, okay? So they send us a fee for that. That gets me reviewing their records, and it gets them an appointment time for us, okay? And then the rest of the fee to be seen initially is payable when they come to the office. Now, in a group setting like this, we're certainly not going to, share what our fees are. I don't think it's really legal to do this, to do that. But what I strongly suggest to you is that, these folks are going to take a good chunk of your time, and you're going to get yourself in a situation where you're not going to want to be as involved in their care down the road if you're not really being compensated for it. I mean, you need to be compensated for it. So from the get-go, I figure it's going to be about 3 hours of my time. I'm going to review their stuff. I'm going to spend an hour with them when they come to my office for their initial visit, and then I'm going to be putting a treatment plan together for them, which we'll say takes about an hour. So for me to get the ball rolling with them, we're going to say is about 3 hours. So if something like that sounds like what you would do, or some other fraction of that amount of time, I'd say just take, whatever 3 hours of your time typically generates in your clinic, and make that your initial fee for your complex patients. That's what we did anyway. So that kind of gives you an idea of how we do that. If whatever, I'll just pick a number out of a hat. If your presence in your clinics, just seeing patients for an hour, generates $300, then maybe $900 would be a good initial fee. Some of the services that you provide probably will be covered by insurance. There's probably some that won't. So, we look at fleshing that out, and I guarantee you, when we see somebody, some of it won't be covered by insurance, and that is good, because them having to pay some money up front puts a significant hurdle up in front of them, and if they're not committed, if they're not willing to do something unreasonable to get in and see you and get rolling with the care that you recommend, if they're hedging on it, it's not going to be successful anyway, not in this population of people, okay? We use the advanced beneficiary notices. We let them know that some of the things that we're doing are not going to be covered by insurance. We do that ahead of time with them as well, and I think that's really been a great thing. I think, a lot of people kind of thought of that as kind of a pain in the tail when Medicare started that a while back, but I think it's very, very good. Now, what we ask of people when they come in terms of information is we have them complete our intake forms before they ever get here, so that's all sent to them. We have them gather up all the records that are associated with whatever their condition is: labs, imaging reports, summary notes, discharge notes from when they were at Olive Life, or whatever the case is. And I think probably the most valuable out of all that stuff is we have them just provide personal narrative describing the journey that they've been on in dealing with this condition. And they just sit down and, I don't get very many handwritten ones anymore, but, they just sit down and type in, what the deal is. And oftentimes the background is so convoluted and the journey is so convoluted that looking at the records, it's really hard to piece together sometimes. And a lot of times they can't get a hold of everything and stuff's missing, or they request it from some facility that's not sending it to them, or whatever. That narrative is just so helpful. And one of my goals is that I know them before I meet them, that I have a sense of a bit of who they are and what they've been through. The other thing is, and I know you see it all the time, when people with complex conditions, you sit down to take their history from them verbally, you can be sitting there a long time. And whatever chunk of time you set aside for that in your office, let's say they sat out in your reception room, they got there late, they sat in the reception room, it took them longer to fill out the stuff than we predicted, and now they're sitting down and they've got quite a tale to tell, okay? And you're burning up the time that you need to really look at them and try to do things justice. So what we do is we just get all that stuff beforehand, okay? So they pay us in part for what we're going to do before we ever see them, so that's good. We get all the information ahead of time so that when they come, we put plenty of lead time on when their appointment is. It's just a greeting at the front desk, and really their paperwork is done. It's 100% done, and so it gets a bunch of other stuff out of the way. Okay? If they're not willing to do that, if they're not willing to go over and above, if they're not willing to do, well, gosh, there's no other chiropractors I go to this stuff. Okay? If they're not willing to do that, they're probably not going to get better with care anyway, not these people. Okay? And they're probably going to wind up frustrating you, and that doesn't do you a lot of good either. So put hurdles between doable and relevant and good hurdles between them wanting to see you and them actually seeing you. I just think that's so important. Okay. So make sure that that the time frames that are going to be involved with getting started, getting things initiated with you, are out and in front of them right away. We always schedule 2 visits. Everybody. It doesn't matter whether it's complex patient or not complex patient. We always start their care with us with 2 visits. They have an initial visit scheduled, and they have a follow-up visit scheduled, called a report of findings visit scheduled, so that we always have that level of commitment once again. Okay, I really don't see too many people that say, hey, doc, man, my neck's been killing me. Check me out. I think you do adjustment and see if we can get me over this thing. They have to be pretty willing to jump through some hoops, and there's a lot of other places that are easier to get into to make that happen than it is at my clinic. So within 1 day or 1 week, somewhere in that range of that initial visit is when we do our report findings visit. And we'll talk a little bit about that as we progress too. Make sure you schedule your formal reevaluations. I think that's really important with all of our patients, but make sure it's down on the calendar. Use a multiple appointment schedule and get that set. They should know that they're going to have to do some things at home. They're going to have to take some ownership of their care. It's not they come to you, you do to them, they receive care, and they get better. They probably had care like that, which can be very successful, but in these folks, they need to take ownership of it by doing more than just when they see you. And there's a lot of stuff that they can do at home to make a big difference for them. And then once again, length of treatment plans need to be realistic. And then kind of the last thing on the commitment is you're asking a lot from them. It needs to be a two-way street. So I try to work hard to be prepared for the visits when I see them, whether it's their initial visits, their follow-ups, their reassessments, or their routine visits. We reassess frequently because we're going to need to kind of ebb and flow, and their care is going to need to evolve as we progress. And we need to take some time to communicate with them. We need to let them know, help them understand what's going on. One of the things that I do as part of that is on that report of findings visit, we talk somewhat specifically about the whys of our recommendations. What's really great, what I really enjoy, in probably the last 5 or 6 years since we've set up that new patient procedure the way I'm kind of sketching for you, is that I don't know if even once in the last, let's say, 5 years, I've said, hey, here's a treatment plan, here's what I want you to do, that I've ever had anybody say anything but let's get started, let's get rolling with it, even though it's a 6-month treatment plan. And I think a big part of that is that, we've asked for a level of commitment that people that aren't willing to do that don't make it that far. They're not going to be there for that report of findings visit because they've weeded themselves out. And in people with complex situations, that's fine. That's fine because you don't want them entering into something that's not going to work for them anyway. We also do kind of like spinal care class, but since I see a lot of people with neurological issues, we do brain class, and so we have a little group class periodically throughout the year, and we just did one last night here at our office. and that provides some more education that I think really is helpful. So I think, Denise, this leads us to our first poll question.
All right, thank you. If everyone will hold down their CTRL key, I will launch the poll now. So we'll give you a few seconds to answer that. Pretty good. We've got 83% voted, and it's been there. There we go, 89, 94, which means there's maybe one more person out there that needs to vote. If it didn't pop up for you, go ahead and type it in the questions box, or you can send me a quick email or a fax and just let me know that you were attending and what the poll was. We're still at 94%. So someone wasn't able to make it. I'm going to go ahead and close the poll, and I'll share the results. And do you see those, Dr. Powell?
I do, yes.
All right.
Thank you. I think that I certainly would vote for C. I think the more you can get commitment from your patients before they ever see you, the better it is, especially the ones that have quite a few hurdles in terms of having successful care in the first place. And I think it will help maximize your success with these folks, and you know, your efforts are more likely to pay off.
So the best time is the third one before the first visit?
Yeah, before the first visit. You know, and certainly I doubt that everyone's typical office procedures are set up that way. But through some years of trial and error, I found that, you know, when you tell somebody that we need to see you this many times a week, you need to do this, you got to go get these labs, you know, you need to change what you're eating, supplementing, whatever, you know, here's the time frames we're talking about, and it's months and months long, and, you know, your insurance isn't going to cover. That you want to get that stuff as much as you can out of the way before the first visit, even though you don't know the details of what those recommendations are. You know that the recommendations are probably going to be what many would consider unreasonable. And, you know, if you're in an unreasonable situation, that is, that's the way to look at it. So let's look at a few other things that are really kind of nice to have an awareness and be prepared for. As we see those slice of patients that have some additional challenges, and certainly some conditions just have some just physical, logistical issues. You know, the more folks that you are successful with that have complex situations, the more they're going to come see you. So, you know, you're probably going to have a few more wheelchairs in your office, and I think most of us have pretty ADA compliant facilities. But, you know, certainly an older facility that was kind of grandfathered in on some stuff, you may not, but you should have some comfort with wheelchairs. You might get a few scrapes on the inside of your doorways from especially some of the bigger motorized ones. It's a really good thing to talk to some of your patients, maybe that are CNAs. I'm sure you've got some CNAs or patients that are patients or nurses. They're usually really good with transferring patients from wheelchair to table or to bed, and you know, have them show you how to do it, because you know, that's a skill that's really helpful. Sometimes the family members there that can give you a hand with that, but transfers and using gait belts and being able to work with people that, let's say you need to do some assessment or some adjusting with the person standing, but they use a walker. Some of those things are just are good to have an awareness of. Many patients with complex situations can't drive themselves, so they're dependent on others for transportation, and for a variety of reasons. And so, you know, there are sometimes issues with on-time appointments. you definitely want to schedule some lead time. You want to let them know ahead of time that sometimes there's a bit of a wait. The reality of it is, if there's a bit of a wait, even though we don't want them to wait, I mean, we want it to just be as nice and quick and convenient as possible once things are rolling. But if they've made it through those other hurdles that I talked about earlier, and they're going, you know what, yes, doc, I'll just tell them what to do. I'll do it. Okay? They don't care if they have to wait a little bit. Not at all. I remember there's one of my patients that I saw that had a stroke. He was about a year, maybe 14 months out. His whole left side was paralyzed. And we did some things with him, seeing him once every 2 weeks. He was coming from, probably about 45 minutes away, had a family member driving him. And so we'd see him once every 2 weeks, and then I'd send him home doing some things. And this was quite a while back. Probably on about the 6th or 7th visit, right after the adjustment, all of a sudden he started to move his left side, his leg and his arm that had been completely paralyzed. And the left side of his face, he was able to smile with it, and that had been completely paralyzed as well. And so, you know, it was pretty cool. It was kind of a little emotional moment, and a window of opportunity obviously opened up. And his sister-in-law had brought him, and she was who always brought him. And, you know, she said, okay, so now, you know, let's go. Once every 2 weeks is not enough. We got some opportunity here. And that was when I was in the office 5 days a week at that time. I'm not now, but I was at that time. And so so she said, you know, he's coming every day next week. And I, no, we're gonna see him, you know, 3 days a week. Yeah, I didn't want to push him too much. I didn't want him to have to travel that much to come over. I think it was late, like this time of year, so I was going, they just don't need to be in the roads when it's wintertime. But his sister-in-law completely got that. If you're in an unreasonable situation, you got to do an unreasonable stuff. So she negotiated me to 4 days a week, and then she just brought him on the 5th day, and they just sat out front. They just sat in the reception room and just waited. And, you know, if, you know, my front desk person told him, you know, he doesn't have any openings for another couple hours, and then maybe we can sneak him in. She goes, that's fine. That's what we're here for. So when people have complex situations and they are on board with doing something about it, they don't care. They will do what it takes as long as you vet that stuff. That particular situation, those folks were willing to do what it takes in spite of me not putting those hurdles in front of them, which I learned a lot from them and other people. So we do that now. It's likely that people with complex conditions are going to have other folks with them, social worker, family member, you know, maybe their adult child is helping them out, or whatever. And so there's likely to be other people in the room, and certainly people that have some of these conditions have cognitive issues. So they don't always understand some of the things that you're trying to share with them. They can't always express themselves as clearly as you'd like. When you work with people with brain injuries, a lot of them have lost their filters. So in terms of what is socially acceptable talk, you may, you know, one of the things that you may be taking on is somebody that says something inappropriate to you or to your staff. And, you know, although that's not acceptable, and you need to let them know that, if you go, you know what, I just know this is part of their condition, then you just make sure that, you know, they spend maybe time in a room instead of out in your reception area, and that that you have some level of tolerance for that. Documentation. So we need to make sure that we come up with a plan and that we can kind of stick with it. So since they're complex, you need to make sure you've got some pretty good documentation. Something that you can look back and go, okay, what was I thinking last time they were here? What was I thinking when I put this plan together? And so I'll show you a little bit of some documentation in just a minute. The other thing is that they've got multiple providers, guaranteed. You need to let them know what you're doing. You know what? You're going to have a higher and higher and higher level of success with these folks that nobody else is, especially if we can incorporate some of these concepts into their treatment plans and into the way that these people actually enter into your clinics. So other providers are going to need to know what you're doing so that they can get people to you. They're going to want to know, who can you help me with? Because I don't care what discipline of healthcare you work in, you got lots of complex patients, and there's a whole lot of them that other providers are going, you know, I really don't like it when this particular condition or this situation comes in. There's nothing we can really do for them. And so, you know, they refer them to somebody else, or they prescribe something and they say, you know, if things aren't going good, come back in a year. And, you know, after talking to some of those docs, they're going, I kind of hope they don't come back in a year. I hope it works out really well for them. It does great. But if it doesn't, I don't know what I'm going to do for them anyway. What they can do for them is get them to you if you let them know. You need to share your documentation with the patient's permission to other providers in your area, especially the ones that are involved in this patient's care. And of course, you need to get their permission, follow all the HIPAA guidelines, and then send it out. You want your name to be familiar to other healthcare providers. Okay? On the report of findings visit, we provide a treatment plan. And this is just an example of one. And so this is a fellow named Les who's 50 years old, and I'm glad I included him because a lot of Les's issues are from, he was in an armored vehicle in Iraq that was attacked, and he suffered a head injury during that. I think we probably call it a concussion, not a traumatic brain injury, but a concussion and some other injuries from that and other service-related injuries. So I'm glad I included Les because that reminds me again that it is Veterans Day, and we need to make sure that our patients today and any of our folks listening that are veterans, that we make sure that we express our appreciation for their service, and Les is certainly among them. On his report of findings, this is what he got from me. Okay, so I took a look at him. This is the second visit, and I say, hey, Les, here's what I think you ought to do. So this is what I put together for patients on that prior to that second visit. And it's different with different people, obviously, but I just want you to look at sort of the major chunks of this. The first one on A is what are we trying to change? B is how are we going to go about doing that in terms of coming into the office, that sort of thing. What's our basic outline of this deal? Letter C is the specifics. What will you actually be doing? What is our step-by-step on this? What are you going to do when you're at the office? What are you going to do when you're at home? And then, so you see those. D are goals. How are we going to know whether we're successful or not? So I've got a variety of goals listed there. Those goals are different for different patients. They're the things that I think, if this is changing, it tells us you're getting better. Okay? If this is changing, this tells us that you're getting better. Les has been having headaches every single day for about 10 years, 8 years, something like that. He's seen lots of different healthcare providers. He works at the VA. He's seen all kinds of folks there. He's had chiropractic care. So as you notice on the goals there, I don't have headache-free for a week or 80% decrease in symptoms, okay? Because in reality, there's a pretty good chance that he's not going to get a decrease in symptoms in a month, okay, at a 4-week time period. But if we look at that A, B, C, D, E, if we can move him towards all those things, I can pretty much guarantee you the guy's going to get a lot better, okay, an awful lot better. So I think it's important to have measurable goals. Now, do we want to have symptom-based ones to some extent? Yes. A lot of times I'll have 3, 4, or 5 measurable goals, and then I'll have one that's symptom-based, you know, and whether it's a frequency of headache or a percentage decrease in symptoms. But these are the big ones that you can measure. And then lastly on there, we have complicating factors, things that are getting in the way of him getting better. And I talk to him about which ones of these can you take control of, okay? And so he can't take control of prior head injuries. He can't do anything about that, okay? But there's a couple on there that he can. And so because he's jumped through enough hurdles before he ever got a chance to get seen, he's willing to do some of this stuff. He's taking it seriously. It's not an offhand, you know, hey, the doc's been telling me to quit smoking for years. You know what, I tried once, whatever. He jumped through enough hurdles, he's going to do what you tell him, okay? So with that in mind, Here's our second poll question, Denise.
Okay, let's see, if you'll all hold down your CTRL key, I'll launch the poll now. We don't have any questions that have come up yet.
All right.
We're at 72% have voted. It's going pretty quick.
All right, all the above, huh?
83%, 89%. If you haven't gotten in yet, okay, I think we have maybe one more person out there. Maybe it's the one that didn't work last time. I'll give a few more seconds. Okay, I'm going to close the poll now and share the results.
Okay, that looks good. And certainly all the above is the appropriate answer, and there was even actually a little bit more than that on the treatment plan on less that I shared with you guys, so that's good. All right. I have quite a few things that I want to try to share with you, and we're no way we're going to get through them all. We got about 15, 14 minutes yet. But I'm going to do my best to share as many gems as I can regarding helping folks with complex situations. So we're going to kind of buzz through some of these on the list, and other ones we're going to take a little bit more time with. So one of them is that you need to make sure, you need to make sure you're working with other folks. The reality of it is what you do is probably not going to be a home run for someone that's like one of those three folks that I put on that list earlier, or for less. Not a one-swing deal. You're part of the team now. You can be a huge part of that team, okay? And you can help prop up the rest of the team. But the reality of it is that you need to be part of the team. The other thing is, you need to try to communicate to the patient and the other providers that you're going to send your documentation to that you're just part of the team. You're doing your best, just like they're doing their best. That needs to be sort of your mindset, because even if maybe some of the other folks on the team really aren't contributing in all that positive a way, when you help this person and things are going really good, and with their permission, you send an update to the other providers, instead of those other providers just losing track of them and kind of being glad they're not showing up again, now they know what happened to them. They're doing great, okay? Somehow they navigated that problem. And they also know that you were probably complimentary regarding those other providers, which makes them feel good. And they also know they can send people to you in the future, if that's who you want to see, if you want to see complex folks, okay? Once again, since a lot of other people have probably looked at this complex patient, you need to have fresh eyes when you look at them. One of the things that I think as chiropractors in general, we all kind of have a tendency towards, and I'm no exception, is going, you know what? Those last two chiropractors that saw this person, they aren't adjusting them like I'm going to adjust them. That's it. They just need to get the right kind of adjustment. I know that the other chiropractors that the vast majority of my patients have seen are very good adjusters, using a variety of techniques, and so that I need to find something else that we're going to do. Adjusting is certainly going to be part of their care pretty much all the time, and maybe we have them go back to the other doc that sent them to me for their adjustments, and I help plug in some other things with them. But we need to look at them with fresh eyes. Definitely don't duplicate what the last person did, okay? There's something else going on here, or they wouldn't be in your office. Those next four things in bold, I'd like to just try to share the mindset of when you see any new patient whatsoever, that we try to get our mindset not so much on here's the diagnosis and here's what we do for that diagnosis, but instead, especially in these folks because their diagnosis is oftentimes non-existent or not accurate or a best guess, you look at them and you go, okay, what's going wrong in their anatomy and physiology? What's going wrong? We're going to record that somewhere, right? Second thing, Okay. What strategy could we come up with to change what's going wrong? Okay. So their hip's not moving right. What strategy could we use to change that? We need to correct the biomechanics of the left hip. They're anemic. What do we actually need to change? Well, we need to increase their red blood cell count, whatever it is, okay? Third thing, how are you actually going to do that? What are the nuts and bolts of making that happen? You know what's wrong. You know what needs to change. Method is how to change that, okay? And, certainly, all of us that do a variety of different things, and we can just think in terms of chiropractic technique, I would hope that with similar training we go, okay, what's going wrong and what needs to change would be the same for us, but our methods might be different, and that's okay. And it's especially okay if we finish off with the fourth thing, is that we need to have some yardstick that we can use to measure whether things are really changing or not, something measurable. And those goals that I had at the end of that treatment plan, those weren't just 1 month or 2 month goals. Some of those things we're going to check on a routine basis and measure to see if we're really going down the right path. Because complicated people get off the path in a hurry, okay? So you want to have specific goals. A lot of times it's really nice to have, a surgical consult or something like that that's hanging out there for this patient. Like at 8 weeks down the road, they've got a surgical consult. Okay, our treatment plan is to get you to this point prior to that surgical consult so you can cancel it. Sometimes those deadlines, those external deadlines, are kind of nice to have. They take a lot of the gray out of the decision making as care progresses. So that's something that you might use. Certainly, everybody that I see gets adjusted. You want to think about, well, gosh, why might their adjustments not be holding? What's getting in the way of this? And one of the biggies that we always address with everybody, and I think this is probably one of the better gems that I can give you, is that you want to try to understand what's going on with their balance system. Okay? Are they falling backwards with their eyes closed and feet together, or to the left, or whatever? If their vestibular system's not quite right, adjustments are not going to hold. It's just guaranteed, because there's going to be an error signal in the brain that thinks they're shifting backwards, for example, and so they're going to be constantly becoming more kyphotic to avoid falling backwards. So you do the adjustment with them, and then in error, they correct for a posturing that's not even there, and it makes it go back out of place. So that doesn't even come close to doing that justice, but I would highly recommend that as part of your exam with all your patients, not just your complex ones, at least stand close to them, put them in Romberg's position, feet together, eyes closed, watch the direction of their sway, and make one of your goals for all of your patients to get them steady. Okay? Methods on how to do that on a lot of them, just getting them adjusted and healthier, they're going to get steadier. And there's lots of other things that a person can do, but at least to just make that one of your goals so that there's no visible sway in Romberg's position is huge. And I think you'll get a lot more mileage out of your adjustments. I think that's a big one. Okay. We already discussed that your patients are going to have a significant amount of homework, and that's part of their commitment. A big challenge in complex patients is, what is step one in their rehab? So a lot of times people have gone through rehab care with PT or speech therapy or OT or whoever it might be, or other chiropractic clinics, and they've, whatever a traditional starting point is, that's where they started. Okay? A lot of people didn't tolerate that very well. They had problems with it, and so they sort of flunked out of care a couple times, and now they're with you. So there's quite a bit that goes into going, okay, where is my starting point with this person? Maybe it's very minimal. Maybe, so like sometimes I have people just start off with just doing a breathing exercise and some eye movements. And that may be just what we start with, or just some stretches, or whatever the case might be. But step one might be much, much less aggressive than we would typically think. Let's jump ahead a little bit here. I'm going to go back. At the bottom of our list here, certainly I think most of us really enjoy seeing children. And there's some challenges that come along with seeing kids and also kids that have complex issues, developmental issues, behavioral, cognitive issues. A big part is you have to get the parents involved. They have to have a very significant commitment. Obviously, kids aren't the decision makers of how often they're going to get to their appointments. It's their parents that are. I get it out in front of them right away that they're going to be doing some things with their kids based on the recommendations that I'm giving them every day after school, for sure. And they either need to be able to make that happen or we shouldn't be starting care. I try to get that out on the table. Everybody is super busy, okay? Nobody has time to do anything. That's the reality of life for so many of us. But when you're in an unreasonable situation, you got to have fun. You got to find time. And if it means that one of the parents has to change things so that they come home from work early and pick up their kids from daycare, get them home and do their stuff with them, if they got to hire somebody else to do that, if you know, the kid's not doing some after-school activity that they were doing because they need that time, then so be it. Let's get committed for 6 months or a year or whatever. Let's get this thing to change so that they can participate in life fully the way they want to and have that busy life they want to have. The other thing is that a lot of schools, if you send a note and say, hey, I need, you know, we need, for this reason, we need an associate at school to do these exercises with this child for 5 to 10 minutes, something not too cumbersome per day. A lot of times they're pretty good about doing that, and that plugs that into the day. Let me look real quickly at the last thing on this list as we're getting kind of towards the end of our hour. I take that back. We're going to go to the top thing. Medications. So let's talk about those just very briefly. Obviously, you're not prescribing medications. You're not taking people off medications. A lot of people would be a heck of a lot healthier without them. Okay? So one of the big helps for us is to look at medications people are taking and go, okay, regardless of the side effects, which ones of these do help your symptoms? Which one of these seem to make things better irregardless of the side effects? A lot of times that helps us understand the mechanism that needs to change in them to actually get them improvements. So we can, so for example, if an SSRI is helping someone, even though they don't like some side effects from it, I'll know in my neurology practice here that we need to do things that you know, promote the serotonin system. Okay, so at any rate, that's one little piece that helps us with medications. Let me jump down to the bottom of this. When you have people with complex issues, you are not going to be successful with their care if they have these other roadblocks. If they're anemic, if they're dysglycemic, and they can't carry fuel to cells, especially the brain, it sort of doesn't matter what you do with them. They're not going to get better. Okay? They've been dealing with this for a long time. If those roadblocks are in place, they're not going to get better. If they have an autoimmune disorder and you stress the system, the autoimmune disorder is going to ramp up. You're going to stress the system for sure. They're not going to get better. I think all of us clinically need to get better at figuring out these things. Look at basic lab work, find ways to measure markers for these issues, and then find ways to correct them and remeasure. That's one of the bigger gems that I can share with you, and that's made a big difference in my practice in the last 4 or 5 years. And so the vast majority of the complex patients that I see, we do at least blood chemistry, CBC, vitamin D, and then sometimes some other things as well, but we at least do that. Denise, I think we're getting close to the end, and here is one more poll question.
All right, let's get this done really quick. If you hold down your CETRL key, we'll launch the poll now. And maybe if I read the question quick, understanding the patient's medication history can allow the chiropractor to, oh, they're already filling it in fast. Look at that go. Okay, we're at 83%, 89. See if we can get to that 94 again. There we go. I'm going to give a few seconds in case that, oh, there we go. We got it 100%. I'll close the poll. and
B
share the
and C
results?
are, thank you, Denise. B and C are correct answers here. So I
Oh,
certainly
both
talked
B
about
and
C for
C?
a minute. Yep, B and C, and so that's good. And I talked about C specifically, but both those are certainly things that are useful, I find, to me in our practice. So as we kind of put this together, I just want to make sure I emphasize the point that that you do things to get commitment, a high level of commitment from your patients, especially those that are going to take quite a bit to help them get better. And then hopefully I shared a few nuts and bolts of some things that we do that you can use in a practical way. I also want to just provide a reminder to what Denise talked about. We've got an exciting class. I think it's going to be a great thing that we want to kind of get going maybe on an annual basis with the ICS, where we actually look at patients on Friday night, and then we go through some kind of condition-specific stuff in more of a traditional classroom setting on Saturday. And so we'll be doing that in January, and we'll be looking specifically at dizziness. For whatever reason, we'll be covering, concussion. We'll be covering benign positional vertigo, Meniere's disease. There's lightheaded conditions that cause dizziness. Medications, antibiotics are a big cause of dizziness. So we'll be looking at all that stuff. So I think that'll be a pretty good time and hopefully really, really useful clinically. So Denise, that's pretty much everything I have. I don't know if there's any questions or not.
No one had typed any questions in. We'll give you a minute if you have anything you want to ask. And thank you very much for the presentation and for helping the doctors better understand how to take care of these difficult patients.
You're welcome. I hope it's been useful for the group.
Yeah. No questions are coming through.
All right.